So good evening again. Welcome everyone for this webinar. So first of all, I'd like to introduce myself. My name is Dr. Mariane Sordi. I am the CMO for Z Systems in Switzerland. And this is the third webinar of a series of webinars that we are making available once per month to our users. And today we are going to bring Dr. Jochen Mellinghoff. He's a dentist practitioner in Germany in a city called Ulm. He has been practicing since 1986, so he has like a massive luggage with information that he can bring today for us. So just a brief CV about him. So obviously he has a DDS, a dental diploma, a dental degree in dentistry, and he's also a specialist in implantology. Other than that, he has a master's degree in oral surgery obtained in Austria and a PhD in public health obtained in Slovakia. He's also author of many articles, especially in ceramic implantology, and he's also an active lecturer. So today he's going to present a webinar entitled 20 Years of the Systems, Milestones and Advancements, where he's going to take us through a journey through 2 decades of innovation and dedication in ceramic implantology, and along with his interactions with the company. So I'm very happy to have you here, Jochen, and I will give you the word to you.
Fine. Thank you, Dr. Sordi, for the kind introduction. Thank you all for having me. I'm proud to have the opportunity to present my experience in ceramic implantology to you, my colleagues, and my friends. Thanks to all who made this possible. When I opened my practice in 1986 as a holistic, biologically oriented, amalgam-free practice, this was an outsider position. It was considered esoteric, maybe a little bit mysterious or weird. Today, the biologic thinking in dentistry is becoming more and more the focus of science, and the general interest in these topics is growing accordingly. In this regard, I'm proud to be able to enrich my implantology activities in the field of ceramic implants in a solid partnership for many years with Z Systems, first as a pioneer, then as a guide. The aim of my presentation is to inspire confidence in the alternative to titanium implantology, to give confidence through experience and the use of quality products in all stages of the procedure. So I'd like to start my presentation. It's called 20 Years of Ceramic Implantology with Z Systems. I assume that my audience is already familiar with the basics of implant dentistry and its science. In this webinar, I only want to talk about my own experiences and research. So, there's a why. I'd like to start with a why. Yes, with my why. Why did I become interested in ceramic implants 24 years ago? There were already implants made of metal. They were used very, very successfully. Please watch an example from my own titanium case collection. Here is one case from 2004. I restored the patient with 2 titanium implants. On the right side, the lateral incisor. On the left side, also the lateral incisor. And when we look at the situation in 2017, we see the implants and the gums in good condition. It's the gum margin that looks a little bit different when you look at the right and the left side. This is because it's a split mouth. I had a split mouth case with a roll lap on the right side and without a roll lap on the left side. And so you see that the gum is most stable, and I think it looks better on the right side. Anyhow, for everyday life, the patient is absolutely happy. We know that a much smaller proportion of our patients have a smile without full gingival involvement. The success rates in titanium implantology were amazing. You look 97% from Busa, 82 till 94% from Holm Pedersen in 2007. That's how they are. The omnipresent titanium implants. The high survival rates of large studies also seem to confirm the success of treatment with titanium implants. The focus is on achieving more treatment options through diversified techniques and mechanics. More, faster, and cheaper for a large market. Nevertheless, in my practice, I often had to explain the compatibility of metals, amalgam in particular, as the main material at that time for fillings and underfillings. It was heavily discussed and attacked in the media. Our patients were very scared about that. Sometimes they worry. They wanted biocompatible materials, especially if they will rest for long-term or permanently in their mouth. A heavy metal-free restoration was on the wish list of many of my patients. Metal in the jaw, they won't accept. Erosion, maybe. Another thing, another problem is peri-implantitis. This is one of my cases in 2008. We worked a lot with gold. We made the dentures from plastic with metal inlays. And this lady was 69 years old and nearly blind. She only could find the difference between light and dark. That's still under construction. And now, can you see my mouse? Can you see it? I hope so. Here is the peri-implantitis area. See also the granulated tissue that comes out of the surroundings of this implant. And now, watch the implant. The implant is nearly out of the bone. We tried to repair that, but I think we couldn't. In 2017, we made a control, and there was pus again. I think in our days and the days before, very difficult to treat. In my beginnings, we were able to switch to resins and ceramics for the separate structure of teeth and implants. these were more readily accepted, even if they were still in great need of improvement at that time. During my presentation, I would like to talk about the fantastic possibilities of these materials in the hands of dental technicians. Implants were also made of metals. So I asked myself, how long will it take before these metals are not longer entirely tolerated by patients? The show of metals you can see on this picture. As a founder of an amalgam-free biological holistic practice, I wanted to address this question that proves me really. I wanted to address it to others, to find a way. I needed information on how and with what I could progress. For this, you need companions. Now my search began. A mentor, a guiding figure, is very helpful when dealing with such complex issues. Professor Sandhaus was to become this guiding figure for me. You can't have a review with ceramic implants without him. I think it's impossible to forget him, because he is the one who found in the 1915s the research into ceramic implants and always remained all the time till his death at the forefront. In 1968, he published his crystal bone screw made of polycrystalline aluminium oxide. In 1982, he was awarded the UNESCO Prize for his research into bioceramics and implantology. His contribution to the specific processing of zirconium dioxide under high pressure and very high temperature was groundbreaking for further developments. This machine looks like a hobby machine from someone who likes to work in the cellar and to invent something. That's what he did. This is the machine for the HIP process, for the hot isostatic pressure process that brought us so forward. The first publication describing zirconia implants appears in 1999. So, ceramic implantology owes a great amount to Professor Sandhaus, who still had ideas when he was over 80 years old. The following picture shows a little bit the milestones, but which milestones are they? They are the following milestones of the studies and of the knowledge. The new ceramic implants were developed on the work of Professor Sandhaus. And I had the possibility to work on it. As head of the DGI Quality Circle and director of the ITI Study Club, I received a great deal of support from Dr. Sebastian Schmiedinger and Dr. Friedemann Petschert. From the DGOI, from Dr. Georg Bayer, from Professor Hubertus Nentwig, from Professor Bergmann, from Professor Grubenau. At the EDI and through the Symposium of Implantology by Professor Joachim Zeller, Dr. Lars Berner, and many, many others. So many thanks to all of them. The year 2004. The question was, are zirconia ceramic implants indicated for long-term clinical use in patients? When I decided to insert my first implant, I opted for implants from the companies Z Systems and Metoxid. Why? I was very convinced that these companies risked losing a lot of reputation with failures in case of ceramic implants. Ceramic implants were a niche product at the time. For me, this meant that I could expect the highest quality. The question today is, are zirconia implants indicated for long-term use in all clinical cases? Try to imagine yourself 24 years ago in the year 2000. Old methods were being criticized. Our patients' expectations were changing. Many were taking a lot more conscious approach to their health. The new roads were already planned and partly built. We just had to drive them. We needed different ways of thinking on our new path. It was important to change our behavior. The patient suddenly took center stage. What a new feeling for dentists. We had to be able to really get excited about doing what the patient wants and promise the maximum benefit. Our pole position was, we had the why, thinking in holistic dentistry. We had the how with our drilling and insertion protocol, and we had the what, a one-piece ceramic implant. So here we go. You can read it on your own. Apical converted, star-shaped, rounded thread, self-tapping, tulip, wide, CAD-CAM optimized shoulder and abutment. Really rare at that time. External hex, flattened side on the abutment, and one piece. To show like the procedure and the protocol was, I'd like to present this video. In this special workflow, you can see the comparison to the titanium implantation. There's not a big difference. This case was done in 2005. It's the same procedure as with titanium implants. So on the course between 2005 and 2018, with a simple laboratory template, a non-guided implantation, and a minor internal sinus lift. 10 years later, the X-ray. 15 years later, the X-ray. 15 years later the clinical outcome. The gingiva around the tooth 1-4 looks much nicer than the one on the 1-5, and that's his natural tooth. We have no inflammation. We have a stippled surface, and we have a pink, nice color. So I'll be starting after that with my first patient. And I'm starting with a monoblock indication, because a monoblock indication is the best indication for beginners with ceramic implantology and also for titanium implantology. In his treatment plan, he wanted all previous metal treatments removed, wanted no bone block augmentation, and had the specific wish that all subsequent treatments be metal-free. This case started my engagement in ceramic implantology. The insertion was in March 2004, and now we see a picture, an X-ray from 2019. And now have a look at the gum. You see the 2-5, see the X-ray, you see it 5 years later. Can I ask you, can you see my mouse? Can you see the mouse? Here you have the X-ray.
Sorry, yes, we can.
You can, yeah? When I have it on this screen, you can see it. I will show you one thing. When I watched this video, this scene of gum, this proportion, and I said, it isn't perfect because I can see the white color here. But it became my benchmark through the years. So always have a look at this part of the implant. This is 2009. You see the light white margin. In 2010, it's a little bit less. In 2013, it disappeared. The X-ray remained on the same level. Now it's 10 years later. Here's the benchmark. Here is a new gingival position, and you see the crowns and the other teeth. The X-rays are similar. Now we go a little bit further, and something interesting happens now. The benchmark is here. The benchmark maybe is here. But how about the neighbor teeth? The neighbor teeth here have gum recession and bone recession. Just watch this. The bone recession with the natural teeth. In 2019, we had that X-ray, we had that clinical view on the implant and the gum, and now see the others. They lost about 2 or 3 millimeters bone. The implant doesn't, or didn't. That's quite interesting. So I want to let people talk about their experience. Jetzt freue ich mich ganz arg, dass wir hier zusammen stehen können nach so vielen Jahren und den Kolleginnen und Kollegen oder auch mal den Patienten sagen können, wie es uns so ergangen ist gemeinsam. So, und jetzt wäre die Frage, heute, einen Tag nach 15 Jahren, wie ist es gegangen?
Perfekt, ohne jegliche Komplikationen. Ich habe das nie bereut und würde es auf jeden Fall sofort wieder machen.
Bei Ihnen kam das Implantat 2 Jahre später, nach einer größeren Augmentation der Kieferhöhle. Was glauben Sie denn, weshalb das so über die vielen Jahre mit der Mundgesundheit so gut funktioniert, dass Sie so gut wie keinerlei Probleme damit haben?
Ja, also erstmal bin ich sehr dankbar, dass ich seitdem, außer zur Prophylaxe, hier nicht zum Bohren oder irgendwie nachbessern kommen musste. Und ich führe es zurück wirklich bei der Auswahl der Materialien, die eine sehr hohe Qualität haben. Auch metallfrei habe ich mich auch entschieden, auch aus gesundheitlichen Gründen. Und natürlich die gute Verarbeitung, Behandlung.
Ja.
Da bin ich sehr zufrieden.
Des Lobes, vielen, vielen Dank. Und Herr Thun, Sie haben ja ein zweites Implantat bekommen, es wird jetzt 2 Jahre alt. Und jetzt hoffen wir, dass wir uns in 13 Jahren wiedersehen und dann feiern wir 15 Jahre zweiteiliges Implantat Oberkiefer rechts.
Genau.
Machen wir es so. Ganz, ganz vielen Dank fürs Kommen. Then he came back in 2023. Please remember the screen from 2019. What do you see now? You see the implant in good condition, and you see the neighbor tooth with a fracture in the ceramic crown and tartar and a little caries. The implant and the gum around the implant are fine. And watch the recessions on the neighbor teeth. Yeah, sometimes we need science, but don't be afraid. I just want to show you that we had studies at the time that favored our approach. In this lecture, I only prefer to talk about observations which concern my own work. This is a case from a young lady, 24 years old. The aesthetic result was very important for her. It's the lateral incisor on the right side, and in my opinion, it looks really nice, and it is very stable. But how about young people like her, 24 years, and their lifetime over maybe 60, 70, or now 80 years? More cases like this. This is a student with 26 years. This is our position. I set 2 implants in the front. And now you see a picture after the healing process, about 1 year later. And the next picture shows you his situation 9 years later. What has happened? The right papilla from the lateral incisor on the right side has filled up a little bit. I would say it became better. The composite filling on the left lateral incisor is a little bit weak. It has a little defect, maybe a little caries. So, in my position in these years, it wasn't easy to take responsibility for such young people. That was a difficult task. The clarification and the desire for ceramic implants had to be explained down to the smallest detail. It still cost me a few sleepless nights. The question was, does this have a chance of lasting a lifetime? Yeah, perhaps it was fate. In 2005, the X-ray shows my first molar on the left side of my upper jaw with an epicholectitis and the generic disposition to parodontitis I received from my mother. And then After extraction, after healing, there came an implant, a Z system C5M implant. And because it was my implant, I made X-rays every year. X-rays, you know, we can discuss about them hours for hours. But here, on the first one in the year 2005, you can imagine that there is nearly no bone. 2006, nearly no bone, not much better. And then we go to 07, 08, 09. And on this picture, you see the bone gain we have with ceramic implants, not in every case, but I think in a percentage, about 30% maybe, or maybe 25%, we have bone gain. That's quite different to titanium implants monotype. So please notice the different informative value depending on either the right angle or half angle of the X-ray procedure. When we have the half angle procedure, and then we compare it with the right angle procedure, we see a big difference. The right side is nearly the real picture. That means ceramic implants behave exactly as titanium monoblock implants. Here is the biological depth. It's about 1,8 millimeters. And that's completely right and biological. So we are now in the year 2016. Now we are 2019. Now we are 2013, 17, 20, and this I've done for you in the year 2024. And also the two projections from half and from right angle. And then you see that there is, in my possibility of observation, no difference between all these years. The clinical use is nearly the same as we saw it in my first patient's case. Here's the implant. The gum and the bone is stable. Here's a blobble base of saliva. The rest is my degenerative generic periodontitis from my mother. That's quite okay. Maybe I need some more fillings. So we can fulfill every patient's wishes for a highly aesthetic level for many years. So that's what we have in the year 2007 till 2011. Wildfang he says something very interesting for me. He said that zirconia implants, he had 14, observation time 12 months, indication single tooth replacement, healing time 6 months. The point is, he made an investigation about the periodontal disease bacterial situation. And this is with titanium, and this is with zirconia. The results were pocket depth between 0 and 3 millimeters, no bleeding upon probing, minimal bacteria contamination, no clustering of bacteria, which is very important for periodontal disease. So that gave me a big progress. During the years, we saw several cases with bone gain around our ceramic monoblock implants, and maybe this is caused by the observations of Wildfang. And then I looked at several implants in my practice. We made a recall for 65 ceramic implants, and we were able to clinically confirm the results of the microbiological examinations at 5 recall appointments. Only implants that were in recall were examined. Not all patients, unfortunately, like follow-up examinations. We had really good results. And here stops the presentation. I have to. So, with all this knowledge, I will not explain this in detail, but I'd like to show you some possibilities in our clinical daily challenge with monoblock implants. Several missing teeth with larger tooth gaps, strong to weak bone offer, and individual factors. And then sometimes you have to start like this. And then to make a sinus lift, a lateral sinus lift, the same surgery. I was allowed with this, was a nice guy who owns a factory. I was allowed to insert 9 implants, 1 stage, 4 immediate implants, 4 were set in healed bone, and the one to replace the first molar needed a lateral sinus lift augmentation. So this was the X-ray after setting the crowns. This was the temporary situation. We always need temporaries. At that time, I made a block for these ones in the right upper jaw. And there's the healing process. You need time. We took 3 months. Then the prosthetic procedure, impression with fixing. The crowns. It was very nice. Technicians were much better then. This is the result X-ray. And this is the clinical outcome. He was about 60 years old and was really happy with his new teeth. Other things, removable dentures. I go through that, you know, the procedure, augmentation, insertion, impressions, caps, and the removable denture. Yes, like Dr. Sordi said, sometimes we publish things. In this case, I really like because it shows something. It shows that you can work with colleagues, and maybe you have a neighbor, a dentist, and you can ask him if he likes to work with you a little bit together. Maybe you meet him in the evening for dinner and talk to him. Ask him, could we work together? So I did it, and I found a lot of friends. And here we did a work with Claudio Caccacci from Munich. And we wanted to prove that 2 implantologists with 2 prosthetic dentists and 2 dental laboratories in 2 different practices in Ulm and Munich could be able to achieve very good results independently of each other if they follow the same protocol. We had 51 implants and 100% success. So we decided to publish it. At that time, publications like that were rare. My conclusion is monoblock ceramic implants are able to do their task in form of function and aesthetic, even in endodontal jaws. So, to follow the goal, the aim that we have indications for all situations, we need two-piece implants. We can use them in lower primary stabilization cases, and we don't need protective splints. Protective healing has advantages, and we can choose the abutments. We have more possibilities in prosthetics. So we began with reduced bone. Reduced bone we often find in the area of 1/6 to 6, means in the upper jaw under the sinus. And for example, I could use weaker bone conditions. The typical situation of an indirect sinus floor augmentation in weak bone and low primary stability is this. These are two cases. One at, they were in immediate loading. So first we tried about 2 millimeters for the indirect sinus lift, and then we go further 3, 4, sometimes 5 millimeters. And the result was a case like this. Indication is shown here, several missing teeth with larger tooth gaps. And when it was done, Dr. George Bayer and Norbert Wischelek, we worked as a team. We published this in the Quintessence Journal in 2016, and we had a really nice outcome and a happy patient. And so I would like to talk about teamwork in southern Germany. Now it's time to talk about that, because it's amazing to work with my friends George and Norbert. We realized that distance is no challenge to successful teamwork in the digital age. Here is a video that shows what was possible in 2019. If you watch that video, imagine what could be possible today. This is Ulm, Augsburg, Landsberg. It's about, for an American, it's nothing. 80, 40, 120 kilometers. And here is the work they do. we didn't want to glue anymore. No more gluing with the abutments. So it was time for a two-piece implant with a screw. And then the systems developed the Z5S. We used it, and I liked it very much. And it was a bone level implant. And in my surgery, I use bone level implants. I really love the gum outcome after prosthetic reconstruction. So a one-step surgery, I made a lateral sinus floor augmentation and an insertion of 3 Z5S implants. So we can watch this. This is done with a burr, and then is ultrasonic surgery to bring the membrane up, but not to disturb it. And this we call elephant foot. The window has to be little, but large enough to bring up the Schneider membrane. And here you can see when it blows through the nose that the membrane is not disturbed. There's no hole in the membrane. That's very, very difficult to operate this. Anyhow, for security, I put in a membrane to preserve the Schneider membrane from being disturbed from the material that comes in, because these materials sometimes are a little bit sharp. Now we drill the implant holes. Always we use the countersink to provide the bone from contraction. And we took out the implant from the package. And the insertion begins with a turn, with a light turn to the left, and then to come into the thread with right turns. Then we use a ratchet and try to find about 35 Newton centimeters. And here we see we are near 35 centimeters. Maybe it's 40, maybe it's 30. With a bone level implant, that doesn't make a difference. So now, this is important. First, you have to put in your material for the sinus lifting. Then you put in the implant, and then you use the bone augmentation material for the lateral side. So the implant is included in bone augmentation material. And then I use a membrane. Maybe it's necessary, maybe it's not. I use a membrane for security. And we see the result. This was the case before. This is the case after. And we won a lot of bone and a lot of stability. 2 years follow-up. development. Here are two almost identical implants. I have had experience with this for a long time. And so the two-piece implant, it looks nearly the same, but it's a bone level implant. And the new one, the follower of the Z5S, is the C5BL. We have a BL for bone level and a TL for tissue level. I use, like I prefer, the bone level one. Ceramic implants are comparable to very successful titanium implant systems. As with the angular systems, the well-known angular system, the Morse conus is activated. The screw, this we have to understand, the screw is not used to hold the abutment. It is used to activate the Morse conus. So it's a total different combination or connection like it is with butt joints implants. Yes, we have a protocol and we have these implants with an extractor like it is with the angular system. If you want to put out something, you have to distract it with an extractor. And here you have the planning, the pieces you can choose. This will be explained by using, for the BL in this case, we have the length 8, 10, 12 millimeters, plus the gingiva formers, abutment, and laboratory analogs, and the scan bodies. The assortment is very large. You can choose between a lot of abutments. So with everything we use in practice, we have a large responsibility. We have a great deal of responsibility. And so we made the Clean Implant Foundation. I did it in 2019, and the Z Systems Z5 are clean. This is important for my practice and for Z Systems, I think. The OP protocol, the operation protocol, is schematic, but you know how to do it because it's the same as with the monoblock. We have already explained to proceed with the osteotomy for the C5M. Here again in the diagram for all three diameters. You can see all three diameters here. And this I wanted to show is this nice screw, this nice ceramic screw, which is in use to bring the conus into position, to activate the Morse conus, and not to hold the crown on the implant. I have patients who don't want any metal in them up. And so we use the ceramic crown. We have the possibility, I think we are the only one in the world who have the possibility to use ceramic screws to activate a Morse conus. And we put in some distance keeper, and comes the filling, and it looks like a natural tooth. The gum is fine, the position is right, so comes the X-ray. It's nearly bone level. Here in this case, I will watch it for several years. Maybe we can see that bone gain I've told about. A deeper insertion of the implant could have been better. Non-guided without DVT, the safety distance to the nerve was a little bit too large. So, immediate implants. Is it possible with two-piece implants? Yes, it is. We made a really smooth extraction with the help of the Binix system. That was in 2019. And then we made the direct implantation, the immediate implantation of a bone level C5BL implant. And this is the outcome 2020. It looks nice. And what you see is that the margin maybe is a little bit better than the one of the natural teeth. And this is 3 years later. Yeah, she needs some dental hygiene, I think. But you can do other cases too. You can do large cases with bone level implants, and you don't have to fear any risk without any protective splint. And you can have happy, happy, happy older people, younger people. Is there a digital future? Yes, it is. It is established. We use an intraoral scanner and the scan bodies, and then you see the procedure, but you know this by heart, I think. So here's the scan body inserted. There's a little view into the mouth and our camera. The advantage of zirconium dioxide with this formula is that we can use different diameters from 3.6 to 5.0. One-piece, two-piece tissue level, and two-piece bone level implants. The digital aids for implantation and subsequent prosthetics can also be used in the same way as with titanium. So it results absolute biocompatibility, no known allergies or intolerances, high stability, extremely low plaque affinity, very good adaptation on the gingiva, no gray shimmer, advantages in terms of aesthetics and patient's acceptance due to the absence of metal. What do we need? Requirements. Yeah, the precise positioning of larger prosthetic restoration has to be proved over the years. A prudent approach with a rigid material has to be known by the users. So they have to be careful and have fun with this very nice protocol and with these very fine implants. And so I will come to an end. This is my friend Sami Sandhaus. He died in 2019 at the age of 92 years. With his death in 2019, I lost a mentor and a friend. So we say, the king is dead, long live the king. We can look forward to seeing who that will be. Thank you very much for your audience. Thank you very much for watching and listening to me. And take care.